have been so happy to be with you today, and it's really a shame, but that the strike was very severe. So and I'm very honored to be within such eminent researchers in neuroimaging, at least virtually. My topic about imaging neurodevelopmental conditions and their clinical challenges, I understood in the broad sense that it is referring to conditions and diseases which interfere with brain development. And I'm trying to talk about this from four different chapters. First, very shortly, history, then summarizing what we have learned. And you have given so beautiful examples already today and yesterday, so that I don't need to stress that very much. And then discuss the role for diagnosis on the basis of that, for diagnosis and therapy, and then give points for challenges and expectations. So now about the history, that will be a very personal summary. When I started in pediatrics in 1979, quite a time ago, the imaging for the child's brain was in its very first development. And we did ultrasound in the A mode. That was the one-dimensional predecessor of B mode, to discover midline shifts and to see whether there was a bleeding or in the infant. So you cannot imagine that anymore, the young of you today. And then we had a very first scan not in Tübingen, but 40 kilometers away in a psychiatric hospital at the end of the 70s. And then the first MR scan, which was a research scan financed by the German Research Council, came in 1984 to Tübingen. And when you look today, what you can do with imaging, it's so extraordinary. You can not only visualize lesions, you can visualize their acuity, you can visualize the function of the brain here in a complex network, and you can visualize the tracts. And that I have these two last examples from a beautiful review. You can visualize perfusion and also complex brain morphometry. And when I now address what we have learned, I would like to start a little bit with normal brain development and stress what is known about structure and function. And again, you have shown so beautiful examples. And here is what you can visualize in the brain architecture. Here, in the early phases, is the gross architecture, and then the fine architecture when it concerns myelination and volume increase. But here it's about, of course, which has been very much addressed the last 1.5 days, cortical folding, and also even you can see here the migrating neurons, and that can be done much better and much more sophisticated. You have put that together in this beautiful review, which has been done by Jessica together with Lucy and Serena, who is here, and people and Manon Benders from Utrecht, and Petra Hüppi from Switzerland. So bringing together really great experts in the domain of imaging the neonatal brain. You can do sophisticated things about brain morphometry. We have heard a lot about it. You can show the tracts with sophisticated advanced methods. You can show perfusion. And here is now an example from the Max Planck Institute in Tübingen. I have worked together quite a lot with Wolfgang Krott, who is still at the Max Planck Institute, and he's absolutely fascinated by intrathalamic and corticothalamic connections. So he illustrated that these complex networks between thalamus and the rest of the brain, here with PTI, and here also combining it with a resting state MRI. I think you gave also good examples of that. And that leads to the next point, namely not just structural parts or aspects, but functional parts. And again, you could show beautifully that already in the infant brain, one can show function with respect to sensory motor, with olfactory. I cannot use my arrow very much because that always makes my image change. So I try to not use that arrow very much. Visual and also language. And for language, that means that already in the infant brain there is a predisposition to have language organized on the left that I would like to make you keep in mind shortly. And then I'm going to the next part, that is during what have we learned with respect to pathological development. And I would like to start with lesion pathology. Here you see the different lesions or different pathology according to the time when it occurs during brain development. The first one is a genetic example of migration defects. Again, both in the older child and the neonate, a migration disorder due to microdeletion P17.3. Then 2 examples of polymicrogyria or schizencephaly in the older child and the neonate. Then typical early 3rd trimester lesions, that means periventricular leukomalacia in its cystic form in the neonate, and in its typical late stage form in the older child, where there is tissue reduction in periventricular gliosis. And these are 2 examples of intraventricular bleeding affecting also the tissue. And at the end, there are typical late 3rd trimester lesions, infarct, and then also lesions of the diencephalon, which are usually which originate from hypoxic ischemic situations around birth. And within our cerebral palsy network in Europe, the surveillance of cerebral palsy, we have made a simple classification of these pathologic conditions, which we called MRI classification or neonatal imaging classification. And I would shortly show you the impact of this. We have we have done a reference and training manual and tried to train our colleagues around Europe with respect to this classification, so that we could collect data from Reykjavik to Greece, from Lisbon to Norway, and show on a population basis that in cerebral palsy, the predominating injury is a white matter injury, which is showing up in around 85% of preterm children. There is in the term-born child with cerebral palsy around 60% of children with cerebral palsy. It is much more variable, and lesions accounting for coming up at the period of birth, that is gray matter injury of diencephalon and cortex, are accounting for only 30%. That explains very well why prevalence of cerebral palsy can be influenced mainly in the infant, in the preterm child. And this is to show you that with the progress in neonatal care, you can not only make survive or decrease mortality in these children, but also make decrease cerebral palsy. And on the long run, and there are data coming from not just from Europe, but also from Australia, we could show that this has impacted also on the overall prevalence of cerebral palsy. So imaging can well illustrate why you can have an impact on the prevalence of cerebral palsy, because the origin of cerebral palsy is mainly when it concerns preterms around birth, so that good neonatal care and good perinatal care can have an impact. And the next part I would like to address shortly is the aspect of morphology and function, plasticity and vulnerability. The German saying here is each beginning is difficult, but it is also a great chance. And the first part, morphology function, is very simple. It is just to show you that the same sort of lesion, that means periventricular lesion, can have very different outcome depending on its extent and topography. On the left, it's only on the left side, and the child has very little problems. In the middle, it is bilateral but mild. So the child has a bilateral spastic cerebral palsy, but is cognitively quite well up. And on the right, it is a severe PVL with a child severe bilateral spastic CP and a severe cognitive delay and visual disorder. So that I would like to keep you in mind that these very simple mechanisms that you imaging tells you about function and in lesions. And if these lesions do not explain what the child shows, then you have to look for something else to explain the child's problem. That is the other part of it. And it is also extremely important for counseling of parents. And the next thing which imaging has made us understand is to see that the great principles which refer to early brain development, namely the principle of greater plasticity and the other principle of greater vulnerability, are not mutually exclusive. The first one is called the Kennard principle. It is Margaret Kennard was a neurobiologist, and she made up how can I say, she could show that the compensatory capacities of the immature developing brain are superior to those of the adult brain, and that is on the basis of lesion studies in monkeys, where she could show that newborn monkeys recover much better from certain brain lesions than adult monkeys. And you have to pay in mind that these certain brain lesions were usually unilateral. On the other hand, there is this HEP principle, a psychobiologist from the US, who a little later had the thesis that the immature brain is more vulnerable because neurons which fire together with wire together, that is his great saying, which concerns the formation of networks. And he had the idea that this process is easily disturbed, and therefore the young brain reacts more sensitively to insults. And what imaging can show you, that these competing hypotheses are not exclusive mutually. That means the compensatory potential of the developing brain is higher in unilateral lesions when you have an intact homotopic area in the other healthy hemisphere which can take over. And that is very clear for language. That is the best model. It is also clear for motor, but not so effective. It does not refer to sensory because there is no homotopic area in the brain. And I would like to show you that it refers to ontogenetic possibilities. And on the other hand, the young brain is more vulnerable when it concerns bilateral lesions, which are the most severe when they involve network hubs and thus disturb network construction. And I would briefly like to show you that. First, about the unilateral lesions. The young brain refers to homotopic mirror structures of the healthy hemisphere. So in a situation where you have a huge lesion which disrupts completely the motor tract, the young brain can refer to an ipsilateral tract. And in a huge lesion affecting the left hemisphere, the patients with such sort of lesions can effectively organize their language in the right hemisphere in comparison to controls. And this can only happen when in the early brain development you have the possibility for that function. That means that the brain refers to structures which are initially established during early brain development in both hemispheres. So for the motor situation, you have when we start, we have double wiring, ipsilateral and contralateral tracts, and on the long run, the ipsilateral tracts disappear. So the brain can, in an early lesion, can keep the ipsilateral tracts, but that is only functional around in the first, second, and early third trimester, and in the infarcts happening at term, it is no longer functional. So it is something which is only functional very early in brain development. Whereas in language, you have, as it is shown here, first a bilateral representation of language, and then in school age is essentially the brain network gets more and more lateralized. So and data are difficult to really put together, but probably a complete taking over of language can happen until the age of 2 or 3 years. Later on, you in such huge lesions, you cannot really compensate totally. And this is an example for bilateral lesions. Here it is a term bone after hypoxic ischemic encephalopathy at 8 months. This child has a severe dyskinetic movement disorder, but is also later on is clear that he has a cognitive problem, and it gets already at that time microcephalic. And the example on the right is a preterm from 26 weeks of gestation at 2 years of corrected age, no movement disorder, but secondary microcephaly, and later on quite clear a cognitive delay. And why is it so? Because in both domains, and we have heard about that, especially in the morning, hubs of network structures. And for instance, the cerebellum, if I may add that to the discussion of the morning, has enormous projections to the brain. Here you can see the number of the millions of projections to different regions of the brain, and that is quite clear that when you disrupt cerebellar development early, it has not motor effects, but rather cognitive effects. And what we also have learned concerns progressive pathology. And I would like to show you one example for a neurogenetic disorder with progression, that is Tay-Sachs disease, GM2 gangliosidosis. Neuroimaging can show you and differentiate that there are 2 clusters with different progression, but these clusters are not entirely differentiated by onset. That in both clusters there can be early onset, and in the second cluster there can also be later onset. But at the beginning, it is not clear which, for instance, also for early diagnosis, which disease course will be taken. And imaging can show you clearly that in Tay-Sachs there is one cluster with very rapid progression where the basal ganglia and the peritrigonal white matter is affected. Whereas in the cluster 2, there is first a normal MR and then predominant infratentorial atrophy. So imaging can help you to differentiate between clusters of dynamics in the same disease, where just as an additional remark, genetics cannot differentiate as clearly. And MR thus plays an important role in the description of the phenotype. And that is the basis for what I would like to show you with respect to diagnosis and therapy. In acquired lesions, the knowledge about morphology and function is extremely important for the diagnosis, and if it explains the clinical features, you can be sure that both are related. If it does not, you have to look for another a diagnosis for the disease. And very importantly, it can, when it concerns early imaging, neonatal imaging, it is very powerful in predicting outcome. There has been a review in JAMA Pediatrics not so long ago that imaging is the best predictor together with neurological items. And when it concerns neurogenetic disorders, pattern recognition is really very important to guide further diagnostic workup together with clinical features. That is, if I may tell a little story from a Tübingen story. At the beginning, with the advent of whole exome sequencing, our geneticists had the idea that they could just sample blood from children with the pediatrician, and they don't need any more pediatric neurologists to explain what they had to look for, because whole exome sequencing will give the answer. I'm exaggerating. In the meantime, we are working extremely well together in putting our different items together, and they ask us what we know about the child to be able to get the better answer in their analysis of the whole exome or whole genome sequencing. And in fact, there are guidelines with respect to CP, for instance, and SCPE has taken it over. MRI has become the most important diagnostic step after history-taking, classifying the CP subtype and the additional conditions, because we know that most is lesional. And whereas in mental retardation, it is a bit different. Without specific abnormalities in history and examination, genetic workup should precede MRI. But on the other hand, when there are phenomena in history and examination which tells you about a specific condition, you could also start with imaging. And so there is some sort of, and it has been raised a little bit in the discussion this morning already, there is a bit a challenge now between imaging and genetics. And when you look at the recent literature, you find, for instance, a review of studies on the diagnostic yield of whole exome sequencing in cerebral palsy. And they conclude that whole exome sequencing should be done as first test, regardless of comorbidities or risk factors, because they argue that the diagnostic yield in CP is similar to that of other neurodevelopmental disorders for which whole exome sequencing is recommended as standard of care. But when you look more closely at that, at these data, the studies which are included all are relying on convenience samples, highly specific, not even how can I say, how highly selective, sorry, and not even centering only on CP, but some including progressive disorders. And themselves, when they looked at their data, they could see that in studies which excluded CP on the basis of risk factors or neuroimaging findings which indicated acquired lesions, their diagnostic yield was much less, namely 20% in comparison when they when that was much higher if it is excluded, namely 40%. But if these factors evidencing acquired lesions or acquired pathology was present, they could yield only 20%. This also argues for having imaging first to guide. But I'm very interested to hear the next two talks about from our genetic colleagues and see what they think about it. We did a study on rare neurogenetic diseases beyond CP and tried to exclude everything which is acquired. So children with lethal brain image were excluded, and even their pathological MRI was helpful. It was atrophy or myelination disorders, things like that. But in such a situation, diagnostic yield was nearly 50%, nearly as high as the other important point when you had clear neurology. That means that neuroimaging as part of the phenotyping guides genetic workup and informs on possible diagnosis. But this is probably a point we can discuss afterwards. So the next part is, or the second last part is the role for therapy. Of course, imaging is extremely important for planning surgery. We have heard that 7 Tesla plays a role yesterday, and here is to show you that fMRI may also play a role, which shows here that in this cortical malformation, the dysplastic cortex carries motor function. Or another example, that imaging is extremely important to monitor success, especially in clinical studies. And this is about hypothermia from the group of King's College. Hypothermia was monitored also with the imaging, and they could show that there was a significant reduction in lesions in the cooled group versus the non-cooled group. But what was extremely important and I think extremely interesting is that the predictive value of MRI findings was similar in both groups. So although there are less lesions, but when they are there after hypothermia, they enable you to predict the future of the child, which is important in the clinical situation. And here is an example of a progressive disorder where imaging in clinical studies is usually included not as a primary but secondary outcome parameter to understand the action or effect of intervention. And here the leukodystrophy changes recede after bone marrow transplantation in comparison to the untreated sister, just to give you one example. And when it concerns to understand disease dynamics or progression for therapy, I gave you an example for Tay-Sachs. This is another one for MLD. Imaging can tell you in indicating specific patterns which predict a specific disease dynamics. Here in MLD, there is the motor area is spared, which indicates a much slower progression than when the motor area is affected very early on. And another example from vanishing white matter, where the different forms show different progression of pathology, which is also important when you do a therapy trial, to understand these changes and to have knowledge from natural history. And of course, as a last thing, and I put it under therapy, but because I think it is so important in everyday life, the imaging can give you a support when it concerns counseling patients and parents. And I try to make it understandable with these 3 children on the videos, that the same lesion type, dependent on extent and topography, can have very different outcome. And now the last and a difficult part for me, because I'm a clinician, I'm really looking at these aspects from a clinical point of view, and I try to summarize some points which I think are important. The imaging is extremely important when it concerns diagnosis and natural history. And in the light of increasingly recognized diseases, you are very much centered on neurodevelopmental disorders, but the broad domain where brain imaging in children is important and refers to the broad domain of child neurology, is very much revolutionized by genetic progress, and we recognize new diseases every day, and for these diseases it is very important to be able to phenotype them. So we need expertise in pattern recognition supported by machine learning, as has been told today. We've tried to start a project of leukodystrophy, which is extremely challenging, I can tell you. And we need knowledge also about morphology function. And I tried to put emphasis on that in my talk because it is very important as a basic knowledge for a clinician. And I think images have the obligation to bring their knowledge to the clinician to make them profit from that in the counseling of parents, in doing better diagnostic workups and so on. Of course, it is a challenge when it concerns developmental alterations and cognition, because there you really cannot rely only on visual inspection. And we need advanced MR methodologies in order to better understand the mechanisms or what is going on during natural history. For instance, in mitochondriopathies or in inflammatory disorders. And all that is about broadening up phenotyping. MR is part of phenotyping to assist genotyping, which is more and more important in pediatric neurology. And for therapy, it is a little bit similar. We need MR as a biomarker or part of phenotyping, as the genotype alone is not really predicting disease dynamics. In many diseases, it is quite clear. And we need advanced MR methodologies to better understand in clinical trials the action and effect of intervention. And we learn more about new diseases every day, and with these diseases recognized, which usually are monogenic disorders, neonatal screening gets more concrete. Neonatal screening is in Europe is more conservative. In the US, you have already much more screened diseases than we have. And early therapy will lead to more need of expertise in early imaging. So you are wanted, if I may say so. But on the other hand, the question is whether we really have a common language and a common understanding. And that is now a very personal remark. In my everyday life as a clinician, I often experience that the knowledge about imaging is not really very great. And it would be so important for people to have that and to be able to use it. And I started my pediatric neurology training with Jean Ecardy in Paris, just to tell you that. And he never looked at a report of an imaging. He always looked at the images themselves, that at the time it was just CT and ultrasound, but still. And images need to exchange with clinicians. That is, I think, an obligation, which is I would like to underline in education and training, and also in meetings. There are a lot of meetings where you certainly go to, but I would shortly at the end quote the European Congress of Magnetic Resonance in Neuropediatrics, which used to take place every 2 years, and now with the pandemics has a little bit died out. And maybe I could motivate you to support and that meeting, that it comes up again, because I always thought that it's such a good forum where images and clinicians can exchange. And thank you very much for. I hope that you could understand and see what I was trying to show you, although I'm quite far away. And I do thank you for your attention, and I'm looking forward to the discussion.